Good evening and welcome to all of you. So we are having our second day of the second month's IRA Scholars Meet 2020. And yesterday we had a wonderful program in reference to imaging. First, we had an ILD in rheumatology practice by Professor Shomnath Kundu, who was the Chief of Chest Medicine from IPGMER Kolkata. He pointed out what are the key issues in reference to ILD in rheumatology practice. And then we had a wonderful session with Anindita from PGI Chandigarh regarding X-ray and MRI. And lastly, we had a radiology, another ultrasound, very important modality by Professor Parashar Ghosh and Dr. Shumandra Mondal from IPGMER Kolkata. Today, we are having another very interesting and exciting program on histopathology. First and foremost, renal histopathology. And as you all know, we are having the support of renal histopathology needs support every day in reference to lupus assessment. So that's whenever there are clinical issues for primary diagnosis, for follow-up, and there are challenging issues as well. So we have with us Professor Ritambara Nada. He's from PGI Chandigarh, and Professor Devashish Danda with President Appler. He was the former President Indian Rheumatology Association. He's the founder, head of Department of Rheumatology and Clinical Immunology, CMC Vellore, and whatnot. He's a lot many things can be told for him. So he will conduct that throughout the whole session. So may I request Professor Danda now to initiate the program. Professor Danda.
Thank you, Professor Ghosh. Thank you for inviting me to chair this session. Uh, as everyone knows, especially the participants, the fellows, and the faculty, that in rheumatology training it has been traditional to have histopathology and even in some cases immunohistochemistry as a part of exam process, mainly to interpret the findings. And today Professor Ghosh has very thoughtfully organized this session and with a very able faculty. So we have the session today in three parts. The first part is will start soon after I introduce the faculty, is on interpretation of renal histopathology in rheumatological diseases, and it will go on for about an hour, followed by about a short session about 45 minutes on panel discussion on histopathology in guiding management of rheumatic disorders, and this will be conducted by very young faculty and the young rheumatology trainees. This will be led by Dr. Chengappa from JIPMA, and followed by the last session again. Dr. Ritambra Nada will come back to lead the last session on interpretation of nerve, muscle, skin, and minor salivary gland histopathology. Um I must take the pleasure of introducing Dr. Ritambra Nada. She is a very eminent pathologist with special interest in renal and GI pathology. She is a professor at PGI Chandigarh in the pathology, and she has been having experience in this area for almost 25 years. She had special fellowship in training at on nephropathology at the University of North Carolina, Chapel Hill, USA, under the eminent guidance of Professor Charles Jennett, and she is also the Vice President of the ISRTP, ex-Secretary and Editor of Indian Society Renal and Transplant Pathology. She is recipient of several awards, including the medals at MD Pathology, for highest academic, is one of the highest academic medals at PGI Chandigarh. She also received gold medals in various subjects in MBBS. Dr. Nada had also Nolkar Award from IAPM for published work in 2009. She also had APCON Plenary Paper Award in 2004. She is a recognized teacher for postdoctoral fellowship in renal and transplant pathology under the aegis of Indian College of Pathologists. She trained 19 fellows, and she also have administrative functions like nodal officer at the Department of Histopathology at PGI. She is a convener of the Biobanking Committee of PGI Chandigarh. She is editor of CPC section of Journal of PGIMR, a very prestigious tradition in PGI. She is author to almost 200 papers in reputed international and national journals, and she has authored several textbook chapters. She is a member reviewer of editorial board of various international and national journals. Her international assignments include she is a member of the communication committee of Renal Pathology Society and a recognized trainer for pathology committee of ISN for Asian countries. So, with all this, I invite Professor Itambra Nada Duseja to this session, and it's a great honor to have you, madam, in our session. And I now request you to start with your deliberations and the teaching. Thank you.
Thank, thank you, sir. And before I begin my talk, I would like to place my thanks to the Indian Rheumatology Association Society for giving me this opportunity to be part of this program where I'm able to interact and teach our younger colleagues, which it's a real privilege, I would say. And special thanks to you, sir, and Dr. Alkendu and Dr. Argya, who mediated whole this whole proceedings. So before I start, I would just like to mention that this is going to be a very simple class where I'm just trying to introduce the patterns and how we go about interpretation of renal biopsies sent from rheumatology units, which is I think a very important part of our diagnostic duties. So before I take up the patterns and the morphology, just few slides about how we expect tissues to reach us, because that becomes very important before we kind of start interpreting that. So getting a right material is of utmost importance. So technically, we should have three cores in each biopsy because all of them has very significant contribution for interpretation. So we need a light microscopy core should be put in 10% neutral buffered formalin. Immunofluorescence tissue we prefer in Michel's media because that allows it to be transferred across the country or across over up to 1 week. So within up to 1 week, there is going to be no damage to the tissue if it is sent in Michel's media. An electron microscopy core should be put in glutaraldehyde, which should be 2 to 3%. And generally it is expected that we take two cores out of which these ends from two of these cores should be put on for EM so that we have both medulla as well as cortex for interpretation. Similarly, immunofluorescence from across these cores should be sent because again just to have for make it sure that cortical tissue is achieved. So, to understand which part is cortex or medulla, our clinicians need to identify these areas by looking at these kind of dots on the kidney biopsy. If you are able to see these dots, that part is cortex, and if these dots are missing, that is medulla. Only exception to that would be in case you have a chronic kidney disease, which generally is not biopsied, then these red dots are likely to be absent. And if by chance you are, for technical reasons, we are not able to get two cores and you have a single core, please send it in a Michel's media for immunofluorescence because the tissue from immunofluorescence, after having done immunofluorescence, we can take up that for light microscopy and subsequently we can even use that for electron microscopy also. So please put it in Michel's media, not for light microscopy upfront because doing immunofluorescence on paraffin embedded tissue is not a very good idea, though in cases of presence of heavy immune deposits we can do immunofluorescence on paraffin embedded tissues as well. So before we come to the patterns, I would like to emphasize that all the kidney
I'm
biopsies
thinking,
are
why
cut
am I
the
not able
thinner
to hear?
section, that is
Like,
3 micrometer,
I mean, going
and
on.
they are routinely stained with PS, Jones, silver stain, Mason's trichrome, and HNE. Occasionally with Congore, depending on the situation, and multiple cuts should be taken because to not to miss any focal lesions. And all these four compartments are interpreted individually. Now, how and just to mention about how do these stains look like? This is PS. The magenta color is the PS positivity. This is Mason's trichrome. The green color is supposed to be for fibrosis, and you can see deposits in the glomerular basement membrane. And this is a silver stain, silver methylamine Jones stain, where the black color is for the basement membrane. And how we use it, I shall just elaborate in subsequent slides. So when we are interpreting these biopsies, we take into account the clinical data which has been provided to us and try to make a diagnosis or multiple diagnosis with an element of clue which sometimes we get from the biopsy itself. And in addition, we try to prognosticate the biopsy in terms of staging the disease, because that is also a very important part of any diagnostic evaluation. So all these clinical patterns you are aware of. For interpreting these, we need to know these the clinical or lab investigations along with that, because interpretation of our morphology and morphology and various immunofluorescence patterns is sometimes dependent upon the what serology positivity is there in that particular individual. And also it becomes important to know the drug history, because in case for example you have a double ANCA positivity, and if patient is on some drugs which are likely to result in ANCA serologist positive, so we may consider that ANCA disease to be due to drugs. So this kind of a, correlation or temporal correlation can only be established when we know these parameters are available with us. Before I proceed on, I want to make the statement very clear that what pattern of morphology we get at and the biopsy is dependent upon at what time of the disease we have biopsied. If suppose you biopsy a disease, a patient at this stage, when the patient is asymptomatic or having only hematuria, we are going likely to see a very early disease. If suppose this patient reports late, and if we are biopsying him somewhere at this point, what we are likely to get is more of a sclerosing lesions, which may be difficult, it may not give you the complete answer. So early diagnosis we should attempt, and the patterns which are going to evolve over the time are going to determine what kind of morphology we are going to see. For adequacy of the biopsy, sometimes we are not able to give you a nice report because we haven't had good number of glomeruli. In lupus, where our some of our diagnostics are dependent upon number of glomeruli which we are seeing, so there the importance of number of glomeruli which are sampled becomes very important for us. Though in a case where there is diagnosis of membranous or amyloidosis, even single glomerulus may be good enough. But the situation where number matters, it is really important for us to see multiple sections and have a adequate number of glomeruli. For same very reason, all the biopsies are cut at multiple levels. Each biopsy generally has 5 cores, and with so many stains available, generally 8 in a case, you would have close to 40 sections evaluated. And if the disease is picked up on, say, suppose this slide, then obviously if serials were not done, we are likely to miss the diagnosis. So that is why sometimes even after on re-evaluation, you get the right diagnosis, not on the first go. Before we understand rest of the morphology, please look at these photographs. This is a normal glomerulus. This is the Bowman's capsule. This part is the mesangium, which is holding these capillary loops together. In one mesangial area, you should not have more than 3 nuclei. If you have more than three nuclei, that accounts for hypercellularity. Basement membranes should be as thin as you are seeing here. That means they should be thinner than the basement membrane of a normal tubule. So that is the reference we use for comparing basement membranes. Endothelium generally on the inner side and capillary loops are empty in a normal situation. This is the Bowman space, and this is also supposed to be empty in a normal situation. And anything here would be a disease process. This is the this is the site of entry of the afferent arteriole. This is Mason's trichrome stain, which is used to evaluate presence of deposits, as well as presence of this green color in the interstitium would indicate presence of fibrosis. This is a silver stain, which is black in color. This is again used for interpretation of basement membrane thickness and its abnormalities. Tubulointerstitial compartment, as you are seeing here, the tubules tends to be back to back. There is no space available here. There's a potential space which is opened up only in a disease process. So in a normal situation, you should have back to back tubules. Arteries and arterioles are present within the biopsy, and here the artery should have an internal elastic lamina and endothelium should be sitting exactly over it, and a 1.5 layer of smooth muscle around it and a cup of adventitia. So this is exactly the normal morphology what you are seeing in this set of photographs. Now, each biopsy is submitted for immunofluorescence, and in immunofluorescence, we have a panel of immunoglobulins, we have a panel of complements, and we have a panel of light chains. These all are part of routine panel, which should be used in each lab, including kappa lambda, because most quite often the monoclonality the diagnosis of that starts from the renal biopsy itself. So please, whenever you are establishing a lab, please don't forget to keep kappa lambda in your panels. IgG, A, and M are the immunoglobulins. Complements most often used are C3 and C1q routinely. Fibrinogen for any evidence of necrosis. Then, uh, uh, in immunofluorescence, the tissue is received in Michel's media, transport media, which is not a fixative. This tends to only coagulate the proteins, retaining their antigenicity. So we wash off this media and it is ready to go for immunofluorescence. In immunofluorescence, we make a note of the pattern of deposits and location of deposits. So location within the glomeruli and outside the glomeruli, and within the glomeruli, whether it's restricted to capillary lumen, wall, or mesangium. Outside the capillary, whether TBM or vessels are involved, and they are always graded on a scale of 0 to 4. Anything more than 2 is considered positive, and the pattern of stainings are granular, linear, or negative, and this we shall show you. I shall show you some examples to make a visual impression of it. So as you see, this is a low power of immunofluorescence. So these are the glomeruli, and you are seeing no this type of granular staining. So this is going to be interpreted as negative. Here, again, we are not seeing any reaction in the glomeruli, so this is negative. But here, you see this IgG intensity is 3 plus, and the deposits are along the glomerular capillary loops as well as in the mesangium. The pattern is granular because you can see dots which are separated by these kind of granular green positivity. As compared to the previous slide, this green positivity is very continuous, as if a sketch pen has been used. So this is not granular, and this is what we call linear positivity. And you are seeing it in the glomeruli, Bowman's capsules, and tubule. So we shall make note of all these because these will have relevance. And what is the antigen? This is IgG, and intensity is 3 plus. Now, in this, we are now seeing IgA, which is localized to mesangium. Why mesangium? Because you could see these capillaries, they are not positive. So this is a negative staining along the capillaries, but only the mesangium, which is showing you about 4 plus positivity. This is C3, again granular pattern, very coarsely distributed, both in the mesangium as well as along the basement membrane. Now, if you have all all the immunoglobulins, that means G, A, and M, and you have both C3 and C1q positive, that is what we call full house pattern, which all of you must be knowing is taken as diagnostic for lupus nephritis. But however, after, if the patient is on treatment, you may have lesser amount of deposits, and some of the immunoglobulin or complements may be missing. So that is the effect of treatment. Presence of C1q always indicates classical pathway activation, which is generally seen in rheumatological diseases. Then kappa and lambda, if they are equally positive, that is what we consider polyclonal. If one of them is only present, then that is what we call monoclonal. It has to be interpreted both in the glomeruli as well as in the tubules. When we are evaluating immunofluorescence, we always keep an eye on extraglomerular positivity. So here you are seeing the nuclei of the tubules are staining with IgG. This is what we call tissue ANA. Even if we don't know the history of patient being of SLE, this is enough for us to indicate that this patient may be having lupus nephritis. Similarly, presence of these deposits along the tubular basement membrane in a granular pattern. Again, the point is granular pattern again would suggest a presence of lupus nephritis, whereas a linear pattern with C4D is not to be considered for lupus nephritis. So pattern, the importance of pattern, I just want to emphasize again and again, because that is what makes the diagnosis different in different situations. This is a normal electron microscopy. As you see here, what we need to do is we chase this capillary loop. It is going like this. What we see on the outside, these are the podocytes. These are the food processes which we are seeing. Normally they should be of this thickness, only this much. When they join together like this, that is what we call food process effacement, which we see in podocytopathy. I shall show you some example of that. This part, which is in the center, is mesangial area. This is the mesangial matrix, which has a color same as of your basement membrane, and these are the mesangial nuclei. This area is the capillary lumen. So this is the endothelium, and endothelium sends these kind of projection all along the capillary basement membranes on the inner side, and anything if present here is endocapillary proliferation. Anything proliferating outside would be a crescent. So before we proceed, I would just take a second to accustom what are the terminologies which we use. So focal, diffuse, segmental, global, mesangial or endocapillary hypercellularity, and extracapillary hypercellularity. I shall show you examples of all: crescent, fibrinoid necrosis, sclerosis, and lobular disease. So a disease is considered diffuse. For that, you need to count total number of glomeruli, and if more than 50% of these glomeruli are affected, then it is a diffuse disease. If less than 50, then you are going to call it a focal disease. When we talk of global and segmental, we are referring to one glomerulus. So if the disease affects whole of the glomerulus, that is global. If it affects a part of it, that is called segmental, right? Then we talk of, this is segmental necrosis, and over the time, if biopsy was done later, it would look like sclerosis. So segmental necrosis would evolve into segmental fibrosis. So this is how it would be important to know at what point of time the biopsy has been taken. Now coming to basement membrane. So see, this is the normal basement membrane. So basement membrane thickening could be due to all these situations. So there could be subepithelial damage as in membranous. There could be subendothelial deposits as you see in class 4, one of the variants of class 4 lupus nephritis. There could be diffuse basement membrane thickening, which you see in diabetes, or basement membrane thickening could be because of splitting of the basement membrane, where you are seeing two layers of basement membrane and mesangial matrix has come in between. So all these are types of basement membrane thickening, but etiologies of them are going to be different, and it becomes important for us to identify them, because to put the disease category into a proper category. So capillary double walls is also a cause of basement membrane thickening, and this is because of new membrane formation as a result of injury. So what we see is a tram track appearance. There is an outer layer, there is an inner layer of silverstein, and mesangial tissue goes in between. So this is what we call tram track appearance, and this is because of basement membrane remodeling. Now coming to mesangial disease. So in case the disease is mesangial, you are going to see capillary loops opened up. They will not contain any cells. So that is what we call mesangial hypercellularity. So depending upon number of nuclei seen here, anything more than 3 is hypercellular. Then depending upon the number of nuclei, we grade our mesangial hypercellularity. Now, what is endocapillary hypercellularity? So, endocapillary hypercellularity, the increased number of cells is within the lumen of capillary. So, what you are not going to see is a free or an empty looking glomerular capillary tufts as we saw in the mesangial hypercellularity. Here it was empty, but here it is occupied by some kind of cells, and depending upon what cells are there, we tend to identify these cells, whether it could be only endothelial cell, neutrophils, or combination of these. Sometimes in later part of the disease, the mesangial matrix will increase along with hypercellularity and basement membrane remodeling. That is what we call a membranoproliferative glomerulonephritis or a lobular pattern, because here the lobules of glomeruli become very prominent. Membranoproliferative because there is a proliferation and there is alteration of glomerular basement membranes. Now, if the proliferation is in the Bowman space, that is what we call as crescent. So this is a crescent, this is a crescent. Depending upon the constituents of the crescent, you will call it cellular. If more than 90% of the crescent is composed of cell, that is called a cellular crescent. A definition of crescent earlier used to be presence of this proliferation occupying 25% of the circumference and at least 3 cell layer. In lupus, this definition has been changed to being only 10% of the circumference, whereas in other situations, still the 25% of the circumference still holds true. The crescent would be fibrocellular if the cellularity and matrix comprise between 25 to 75% of the whole tissue. And if more than 75% of this, the crescent is composed of matrix, then it is called fibrous crescent. Another important question which most often is asked is how will you differentiate between an intraglomerular fibrosis and a fibrous crescent? In case of crescent, since it dissects your glomerular tuft, it divides your glomerular tuft. So that is what is crescent, whereas the intraglomerular fibrosis will be around the glomerulus and it will sort of strangulate your glomerulus, not divide it. So this is what is an intraglomerular fibrosis in a sclerosed glomerulus, whereas this one is a crescent. One important point to remember is that crescent always rests on the Bowman's capsule, whereas the collapse, there's another proliferation which happens in the Bowman space, which is called collapse, that happens over the glomerular tuft. So in that case, there would be no connection between the proliferation and the Bowman's space. So this is a hypercellularity in the Bowman space, but it is resting on the collapsed tuft. And it shows you mitosis, which is not seen in the cases of crescent. This again just to emphasize that collapse is on the glomerular tuft, not resting on the Bowman's capsule. Now coming to lupus. So now I shall, after having done the patterns, I will touch upon what are the rheumatological diseases where lupus, the biopsies are sent to nephropathologists. So most important or most common one is lupus nephritis, and our role in that case is to give you a class, severity, give you both activity and chronicity, and you people know that the clinical sometimes there's a discorrelation between the clinical findings and the biopsy. There are guidelines when the tissue when the patient is to be biopsied. I think you people are better, you all are aware of it. Whenever we receive biopsy, as a pathologist, we tend to classify it into four classes, and this classification system was given in 2004, where we classify lupus nephritis into four classes, and this has been changed over the time, because there was literature to support that some change was required. This diagram, as I'm just showing you the pattern which was identified earlier in the previous classification, and this classification is largely based on light microscopy and immunofluorescence. EM is not generally part of these diagnostic classes, though it does helps us in refining the diagnosis. You are seeing this G and S here, which is abolished in the updated system, which was updated in 2018. So, what are the changes? I'll just mention before I go on to describe the individual of one of it. That cutoff for mesangial hypercellulitis were not available. Definition earlier we used to call it endocapillary proliferation. In fact, it is a hypercellularity, not proliferation. So it has been changed. For crescents, earlier we used to take 25%. Now it's 10% cutoff. Definitions for adhesions, for necrosis, for segmental and global sclerosis were not there. Now they have been defined. And so there has been more clarity as to how the lesions have to be interpreted. So what now, let's see what are the classes. So class 1 is minimal mesangial disease. That means on morphology it will be absolutely normal looking. You will have only mesangial deposits. On EM also you see normal. You don't see any presence of subendothelial or subepithelial deposits. And EM at the best you may have some mesangial deposits. So this is class 1, which is very rare to see in a biopsy unless a protocol biopsy is done. The class 2 is a mesangial-proliferative disease, where you will see proliferation in the mesangium and capillary loops are patent. Immunofluorescence will be seen only in the mesangium. When I'm talking of immunofluorescence, I'm meaning full house pattern, as I had already talked about while discussing immunofluorescence. So all immunoglobulins, presence of C1q, and both kappa lambda light chains will be present. So here it will be restricted to mesangial region. Occasionally it may extend to the basement membrane, but it will be only occasional. And EM will confirm the mesangial deposits like this. Class 4 disease 3 and 4 are called focal and diffuse lupus nephritis. Please note that it is only focal and diffuse lupus nephritis. We are not using a term proliferative. Why? Because there are going to be situations where there is no proliferation, on only basement membrane thickening is there. So it is only focal or diffuse, and kind of proliferations are also variable. So that's why it has been left as far as heading is concerned, it is only focal or diffuse. So what kind of pathology we are going to see? It could be endocapillary proliferation, it could be extracapillary proliferation or a crescent. There could be only diffuse basement membrane thickening with subendothelial deposits, what we call wire loops. There could be these kind of a hyaline thrombi, which are nothing but subendothelial deposits which are protruding into the lumen, or it could be only necrosis, or it could even be sclerosis. So lesions which will be encountered in a focal or diffuse or class 3 or focal for lupus nephritis could be either one of them. The distinction between them would depend upon, I'll just tell you in a minute. And this is just to emphasize once again that even in absence of basement membrane, in absence of proliferation, simply thickening of basement membrane, which we call wire loops because of their three-dimensional structures, and presence of massive subendothelial, these red deposits, is also included in class 3 or 4. And lupus is one disease where pleomorphism, that means different type of morphology in the same biopsy, is very commonly seen. You may have only mesangial proliferation in one glomerulus, endocapillary one, crescent in one glomerulus, and two may have this kind of exudative pattern where lots of neutrophils are there. So this is what we call pleomorphism. So pleomorphism of a pattern is an important sign of lupus nephritis, even if we don't know that the patient is of a SLE. Similarly, presence of lymphoid follicles in a kidney biopsy are also a clue towards it being of a lupus patient. So distinction between class 3 and 4 would depend upon whether the lesions were present in less than 50% of the glomeruli, or they were present in more than 50% of the glomeruli. If in more than 50%, it is class 4, less than 50%, it's going to be class 3. So since these are active diseases, we always try to give you activity and chronicity indices, because that helps you decide whether you need to hit the patient hard with the treatment or not. So if you have a high chronicity score, which is dependent upon glomerulosclerosis, fibrous crescents, tubular atrophy, and interstitial fibrosis, each one of them are graded over a score of 25%, 25 to 50, and more than 50, and so on for each parameter. Similarly, the activity score is based upon endocapillary hypercellularity, presence of neutrophils or kerorexes, fibrinoid necrosis, hyaline deposits, crescents which are either cellular or fibrocellular, and interstitial inflammation. These have also been modified in the current classification system, and we give more importance to fibrinoid necrosis and cellular crescents. They are, whatever score is achieved in this are multiplied by 2, because they matter most for the therapeutic purposes. And all these are graded on the scale of 25. So less than 25, 25 to 50, and more than 50% of the glomeruli. So as you see, it is a percent of glomeruli. So here you need to have adequate number of glomeruli for interpretation. If you have just maybe 3 or 4 glomeruli, our activity and chronicity scoring is going to be fallacious. So that's why it becomes important to have an adequate number of glomeruli in each biopsy. So what are these parameters? Just to show you: endocapillary proliferation like this, presence of fibrinoid necrosis, presence of a cellular crescent, presence of subendothelial deposits or the wire loops or hyaline thrombi. These are all activity points. Presence of active inflammation in absence of any green colored fibrosis. This inflammation is not to be interpreted in these green areas. Only the active inflammation is to be taken for activity. For chronicity, we take into account fibrosis, whether segmental or global, presence of fibrous crescents, and presence of tubular atrophy. Just a couple of pictures of electron microscopy. So in class or 3 or 4, we are going to have subendothelial deposits, and these are the mesangial deposits, because this is the capillary loop. Whenever there are massive subendothelial deposits, we always make a point to look at it at a higher magnification, because all of you must be knowing of these thumbprints. These thumbprints are a sign of increased alpha interferon levels, and these are markers of increased alpha interferon activity. So these are almost quite often seen in class 4 lupus nephritis. So whenever we see massive deposits, we tend to look for them. These are called fingerprint or thumbprint sign. Then we come to class 5 lupus, which is a non-proliferative. Here what we see is diffuse basement membrane thickening, which we see on silver as thickened membranes as compared to this thing, and you see spikes. Spikes are because of deposition of basement membrane in between these deposits. And as you see here, it is going to be a full house pattern along the basement membrane with IgG, AM, C3 along with C3 and C1q. EM in this case is going to show us massive subepithelial deposits like this along with mesangial deposits. In primary membranous, we do not see mesangial deposits. These are the subepithelial deposits. In class, you can have combination of class 3 and 4 with lupus, and for that what we need is at least 50% of the tuft in 50% of the glomeruli should have these deposits by light microscopy and or immunofluorescence, not EM. So if you are able to see wire loops and presence of subepithelial deposits on IF, then you add a class 5 if they are present in more than 50% of the tufts. So when you have combination of classes, you are going to see subendothelial as well as subepithelial deposits. Class 6 lupus nephritis is when you have more than 50% of the glomeruli are sclerosed, but this glomerular sclerosis is supposed to be because of lupus nephritis only, not because of arterionephrosclerosis in the subcortical region. There should not be any residual activity in these sclerosed glomeruli. So, as we see, the frequency of histological pattern in lupus nephritis, most often when we get biopsies, the most often patterns which have been documented in different series is class 4, as you see here, and generally the classes do correlate to some extent with the presentation. Like class 1 and 2 generally tends to have asymptomatic hematuria or proteinuria, whereas class 3 and 4 would have either nephrotic or nephritic syndrome along with renal failure, and class 6 would have presence of renal failure. So there is some kind of correlation with the presentation, though this is not very 100% true. In tubular interstitial compartment, most often the damage is seen in class 3 and 4, more so in 4. You may have lymphomononuclear infiltrate, which may or may not be accompanied with presence of these immunofluorescence along the tubular basement membranes. There is no correlation between the presence of deposits and inflammation which we see. One third of the lupus nephritis patients may have a silent lupus nephritis, mean to say that biopsy is done for some other reason and we get to see the morphological evidence of lupus nephritis. Vascular lesions are very important to interpret, and these are the patterns which we can see. There are 5 patterns which we are seeing, most common being arteriosclerosis, and each one of them adds to the presence of which is not considered good other than this. The category 1 and 5 are the ones which are kind of benign, but other 3 categories generally adds a bad prognostic point to the interpretation. So if you have a normal morphology and you see presence of immunofluorescence on within the vessel, that is what we call uncomplicated vascular immune deposit, which is one of the very common thing to happen. If you have presence of deposits in the basement in an artery subendothelial in location, it can result in an infarct. This is from an autopsy, and there is no inflammation and there is no presence of fibrin here, and only immunoglobulins are seen here. That is what we call lupus vasculopathy. So you have presence of deposits. It is almost similar to hyaline thrombi or wire loops seen in glomerular capillary loops. So you are seeing deposits of immunoglobulins within the lumen of a capillary without any damage in the form of fibrinoid necrosis or inflammation. Another important vascular injury which can be seen is presence of this kind of a fibrin within the lumen and in the wall, along with presence of fibrin in absence of immunoglobulins. That is what we call thrombotic microangiopathy. This can be seen in arteries or arterioles and even within the glomeruli. When this is present, then as a morphologist, we can reach only up to this point, that we will tell you that there is either glomerular or vascular thrombotic microangiopathy. After that, we need to distinguish whether this is part of HUS-TTP syndrome by doing investigation of alternate complement pathway and presence of von Willebrand factor. Then whether it is because of APLA syndrome, if there is APLA antibodies are present, whether it is part of malignant hypertension or scleroderma. And third type of vascular involvement is called necrotizing vasculitis, where you are having both fibrin as well as inflammation in the wall, resulting in damage of this arterial component with a break in internal elastic lamina. And these areas of inflammation and necrosis are rich in immunoglobulins, complements, and having even light chains. So if you have immune mediated damage, which is showing you inflammation and fibrin, that is what we call necrotizing vasculitis, which is very uncommon, seen in less than 1% of the renal biopsies, 1% of the lupus nephritis. But once present, this is not a good sign to have. So this is all which we report in cases of lupus nephritis. Now another terminology which is used is lupus podocytopathy. So in these cases, what you have is on morphology a known case of lupus nephritis, which doesn't have any history of any intake of NSAIDs or before the onset of the symptoms, because we are trying because morphologically it is almost like a minimal chain disease. You have a normal glomerulus, more or less, absence of any immune deposits, and EM shows you presence of food process effacement. So this is what we call lupus podocytopathy. So morphologically, it is going to be normal. There can be a collapse present. Only mesangial deposits might be there, which may or may not be there. And what you are supposed to see is effacement of food processes in a patient who is proteinuric. That is when we are going to label it as lupus podocytopathy. In case a patient present is patient has lupus nephritis or ANA positivity, and you see thick and reduplicated basement membranes like this, which are negative on immunofluorescence, and an artery shows you a reduplicated thrombus. And on EM, again, we do not find any immune deposits, only we find evidence of expansion of subendothelial space, what we see in a thrombotic microangiopathy. This is what we see in APSN or anti-phospholipid syndrome nephropathy. So a negative IF, reduplicated membranes, and presence of subendothelial expansion in a patient having antiphospholipid antibodies positive would be a diagnosis of APSN, and there would be associated damage in the interstitium. So just to summarize, on a renal biopsy, what we see is whether there is no hypercellularity, mesangial hypercellularity, class 1 and 2, depending upon proliferations or wire loops. If they are less than 50% and more than 50%, class 3 or 4. And if there is only basement membrane thickening, class 5. And if they are closed, class 6. That is how a lupus biopsy would be evaluated. Now coming to another rheumatological disease, that is vasculitic diseases. So here I've already talked about the presence of crescents. For to label a disease as crescentic, you need the presence of these crescents in more than 50% of the total number of counted glomeruli. So once you have established the disease is crescentic, then you look at underlying tuft. If the tuft is normal looking, that normal in the sense that there's no proliferation, absence of proliferation, presence of necrosis would indicate to you that this could be a either anti-GBM disease or a post-immune GN. There could be presence of this kind of granulomatous glomerulitis. There could be rupture of basement membrane. Then you look at immunofluorescence. If the immunofluorescence shows you a linear pattern, then this is anti-GBM disease. If with a normal glomerular morphology and absence of endocapillary proliferation, in a crescentic case, you don't find immunoglobulins or complements, then you label it to be post-immune crescentic. Just to highlight the differences between granular and linear positivity. And if you have endocapillary proliferation and a full house pattern, then that is a crescentic of immune complex type. Quite often it could be lupus or it could be IG or anything. So how we differentiate between crescentic is we pay attention to these parameters: the presence of crescents and age of crescents. So I shall just tell you, age of crescents is all the crescents would be of same age in cases of anti-GBM, where they are going to be of different age in post-immune and could be same or different in cases of immune-mediated. Necrotizing lesions could be present in all, but more often in anti-GBM and post-immune. Periglomerular granulomas are again could be seen in any of these. Endocapillary proliferation obviously is only seen in immune-mediated disease, and double contours again would be more often seen in immune-mediated disease. So what helps us distinguish on morphology would be presence of same age of crescents would indicate anti-GBM in glomeruli. Normal underlying tuft would indicate either of them. Proliferation would indicate presence of immune disease. Then we come to interstitium. If there are interstitial granulomas are present, then likely to be post-immune. If there are too many plasma cells, then it is likely to be IgG4. Too many IgG4 positive cells, then it is likely to be post-immune. And presence of vasculitis is seen in post-immune, and rarely it could be seen in immune-mediated disease, but then it is going to be positive for immunoglobulins. So this is how we, on morphology and by immunofluorescence, tend to distinguish between crescentic gene. uh, and as I mentioned earlier also, so proliferation and necrosis would be seen as sclerosing disease depending upon time of our biopsy. There are parameters for prognostication and chronicity within the biopsy, which we always try to do. In cases of post-immune gene, there's a system called a burden system for classification, which we use to classify the disease. Other morphologies which can be seen in cases of rheumatological disease are presence of amyloidosis, most often with rheumatoid arthritis or other connective disorders. So how we pick up those? Presence of basement membrane thickening, which is PS negative and silver negative, which on congruent stain is orange in color. On polarizing, it gives you this kind of apple green birefringence. And on immunohistochemistry, it stains positive with serum amyloid associated protein. Such as disease would be a secondary amyloidosis in a setting of autoimmune disease. Similarly, we can have secondary membranous in cases of rheumatoid arthritis or other connective tissue diseases. Here, as seen in lupus, there will be basement membrane thickening, presence of C1q along with IgG, but this will be PLA2R negative because most often primary membranous are PLA2R positive in 70% of the cases, which is seen as this kind of granular positivity, whereas negative Plar stain is just dot-like thing seen in podocytes. In cases of scleroderma crisis, what we see is a hyperproliferative mucoidy thickening of the arteries. Mucoidy, we mean, is this kind of a bluish mucinous material seen in the intima. That is what is seen in scleroderma crisis. So I think this is all we see in cases of rheumatological diseases. One I didn't mention is IgG for related disease, because I thought maybe we are more concerned. I was more concentrating on glomerular diseases than this thing. In making up all these on evaluation, my whole team of which is led by Dr. Ashwini, our nephrologist, rheumatologist, and Ma'am Joshi, who taught me. I owe all these diagnostics to them. Thank you so much for listening.
Thank you, Professor Ritamra, for such a lovely presentation with very beautiful slides and explaining both the HNE and immunohistochemistry so well. Uh, I am I supposed to take the questions now? There are a couple of questions. It's better to finish off if you don't mind. There's one question from Sahana Baliga. She says, "Could you explain, please, about the collapse and crescents again?"
Okay. So collapse and crescent. Shall I show? Okay. So crescent is basically a proliferation. Both of them are proliferation within the Bowman's space. So if this proliferation is resting on the Bowman's capsule, the genesis of crescent is a rupture of glomerular basement membrane. So it incites a reaction. The the Bowman's capsule tends to give a help. So this proliferation starts from the Bowman's capsule. So this proliferation will always rest on Bowman's capsule. Whereas collapse is a kind of a podocytic disease where your endothelium is damaged. So as a result of that, your podocytes, which are cells present on the outside of the glomerular basement membrane, they start proliferating. So this whole proliferation is resting on the glomerular tuft. It has no connection with the Bowman's capsule. So this kind of collapse, clinically, it presents with a very heavy proteinuria, whereas crescentic disease presents with a nephritic nephritic kind of presentation. So this is the difference between collapse and crescent or crescentic GN.
Thank you.
Presentations are different and morphologies are different.
Thank you. Two more very short questions. This is one from Dr. Rudrapan. He says, how do we recognize age of crescents on histopathology?
So age of crescents basically is basically by composition of those crescents, because see, the initiation point of crescent is rupture of glomerular basement membrane. Fibrin is released, neutrophils come into action, which are later replaced by monocytes. So anything which has more of fibrin, monocytes, neutrophils, no matrix is a cellular acute crescent. Gradually this will be there will be reaction and matrix would be laid out. So neutrophil, monocytes, fibrin will become less, more of blue material will come, that will be a fibrocellular crescent. And after some time all the acute injury would be subsided, and you won't see any neutrophils, no fibrin, nothing, only matrix is seen. That is called fibrous crescent. So that is how they age, according to the what is the reaction of our body and how our body tries to sort of heal or seal that damaged capillary.
Thank you. The last question of this session is from Dr. Rashi Maheshwari. She's asking, what is the difference between secondary membranous glomerulopathy, secondary to lupus, and class 5 lupus nephritis?
Second, class 5 lupus is secondary membranous only. Primary membranous we call when it is by in situ antigen antibody reaction to podocytic antigens, which most often, as we know, is PLAR or thrombospondin like 7 domain. In cases of secondary membranous, it is the circulating immune complexes which go via mesangium and tend to locate in the subepithelial location. So, in that case, you will always have deposits in the mesangium as well as in subepithelial location. And these are negative for PLA2R and thrombospondin. In these cases, another antigen which we call exotoxin 1 and 2 have been discovered, which can stain these cases. So secondary membranous is generally C1q mediated, whereas primary membranous does not have C1q, which is a component of classical pathway. So secondary is because of circulating immune complexes which go and deposit there.
Thank you very much. I think with this we'll end this particular part of the session. We now move on to the next part of the session, which is a panel discussion. On role of histopathology in guiding management in rheumatological disorders. Now, this will be moderated by Dr. Chengappa. He's from JIPMER, a consultant from JIPMER, and the panelists Dr. Sai Kumar from JIPMER, Dr. Anup Matthew from JIPMER, Dr. Amrita from KIMS, Dr. Abita from KIMS, Dr. Digvijay from KGMU, and Dr. Rudrapan from SGPGI, and Dr. Kunal from KGMU. So I now hand over the session to Dr. Chengappa. Dr. Chengappa, over to you.
Yes, sir. Thank you so much. Thank you for the introduction. Good evening, everyone. We have listened to all the histopathology. We have watched some slides. Now it comes to clinical context. So when we order a biopsy, we always want to know what is this biopsy going to add to our clinical decision and to the therapeutics, and what is it going to do to our patient. Can we actually prognosticate the patient, or is it a useless endeavor that we all do? Do we really need to do a biopsy? So today we'll be discussing it. The panel discussion will go in terms of, first of all, we'll have to discuss, do we really have to do a biopsy or not? Then we will look at, is every proteinuria in lupus really lupus nephritis or something else? Then we look at a scenario where we have a pregnancy with MAHA, which is a really big dilemma for all clinicians, followed by a closely related APS nephropathy. And then We'll go into some findings of renal findings in Sjogren syndrome. Should we really do a biopsy in Sjogren syndrome at all? Finally, we'll end it with a vasculitis. To start off, to do or not to do, renal biopsy needs expertise. There is a risk of bleed. Patient needs admission. Why not start off an immunosuppression, especially in lupus, when there is something suggestive of renal disease? So is it really required? Does doing a renal biopsy really change the outcome, really change the treatment, really change the prognosis for the patient? Can we really do better with a biopsy or not? This will be discussed by Dr. Sai. And over to Sai.
Good evening, everyone. I'm Dr. Sai Kumar from IPGMER. I'm senior assistant. So today we'll be discussing is renal biopsy really necessary in lupus nephritis? Uh, uh, with ARMS trial showing MMF equivalent to cyclophosphamide in proliferative lupus nephritis, MMF found being useful in class 5 lupus nephritis as well. The role of renal biopsy has come into a question whether to do a renal biopsy or not initially. So in my clinical care setting, whether I do a renal biopsy or not, we'll discuss in further slides. So I will do a renal biopsy if it helps me in choosing an immunosuppression or stopping an immunosuppression in my patients. As we have known, class 3 and class 4 will guide us in starting higher immunosuppression or coexisting presence of a combined classes like class 3 with a class 5 or class 4 with a class 5 will guide us in starting an higher immunosuppression. Apart from this, with the availability of various induction regimens like high dose cyclophosphamide, low dose cyclophosphamide, and MMF, presence of crescents or necrosis with more than 25% of glomeruli is needs a higher dose cyclophosphamide to have a good renal outcome. This has been illustrated by EULAR guidelines as well. Apart from this, renal biopsy can help in tapering immunosuppression in patients who are on chronic immunosuppressive therapy. So tapering will decrease the immunosuppressive exposure to them and unnecessary cost for the patient. So in this study where they have done repeat renal biopsies in patients who had achieved remission after 3 years of immunosuppression, 70% are inactive disease. This means that 70% of people can be tapered of their immunosuppression effectively, and 30% had active disease whom immunosuppression need to be titrated. So these are this is one of the advantage. I'll also do an renal biopsy. It will help me to prognosticate my patients, like prognosticate in the sense that it would help me to choose which patients need to be monitored closely, whose investigations need to be done nearby, and who has to have a repeat follow-ups in a OPD setting. So the various markers like in proliferative lupus nephritis, presence of an initial high activity score or a chronicity score uh, is a risk factor for ESRD or CKD. Or presence of segmental lesions or necrotizing lesions in more than 50% of glomeruli is also a risk factor for end-stage renal disease. Apart from this, interstitial infiltration, tubular atrophy, and interstitial fibrosis, these are also a risk factor, and it can help in prognosis and it can help in predicting the renal outcome as well. I will also do a renal biopsy if it helps me to differentiate an alternate diagnosis if it is coexisting in this patient. So, for example, if you have a patient who is a chronic diabetic and he has an SLE as well, and he has a proteinuria, doing a renal biopsy will help me to differentiate between whether it is a lupus nephritis or it is a diabetic nephropathy which is causing the proteinuria, and avoiding unnecessary immunosuppression in these patients. Similar scenarios can be seen with FSGS, IgM nephropathy, amyloidosis, arterionephrosclerosis, thin basement membrane lesion, and acute interstitial nephritis, which is common secondary to the NSAID uses as well. Other advantage of doing a renal biopsy is that all proteinurias are not secondary to immune complex mediated diseases. For example, if a patient is having a thrombotic microangiopathy, which can also cause proteinuria, the treatment for it is anticoagulation, not mere immunosuppression. And this TMA is reported up to 25% of lupus nephritis biopsies. Other than this, as we have discussed now, lupus podocytopathy, which needs a different management compared to that of other class 3 or class 4 lupus nephritis as such. And in the era of personalized medicine, with a renal biopsy, what is for the future? Like renal biopsy has a role in research as well, and it can, with the help of proteomic analysis and transcriptomic analysis of kidney biopsy, we can identify therapeutic response biomarkers and inflammatory pathways, and which can we with this we can tailor a standard care therapies for a person based on predicted response. If a patient, if the same person is going to relapse, then we can do a repeat renal biopsy and see the what inflammatory pathways are involved, and we can tailor the therapies to block these pathways. This will help in personalized medicine as well as devising new medicine in SLE, this therapeutic armamentarium as well. But what are the hindrances, what it will cause, like why in what are the major concerns which will hinder me from doing a renal biopsy is that procedure related complications. The common procedure related complication is transient macroscopic hematuria, RBC transfusion, requirement for RBC transfusion, requirement for angiographic embolization, nephrectomy to control bleeding, and death. As we can see in this systematic review of 36 studies which was published in 2012, the incidence of all these risk factors is less than 5%. But with the advantages what I can get from previous slide what we have discussed, this looks little less. And the other disadvantages are inadequate expertise and unnecessary anxiety and apprehension for the patient. So with this discussion whether I will do a renal biopsy or is renal biopsy really necessary in lupus nephritis is yes, because of the advantages what we get. And as currently there are no reliable biomarkers, non-invasive biomarkers, renal biopsy still remains the gold standard for diagnosing lupus nephritis in guiding our clinical management. Thank you.
Thank you, Dr. Sai, for the short presentation. So you have convinced us that renal biopsy is required. Now Dr. Amrita will show us why it is actually essential, and not all proteinuria in lupus is actually lupus nephritis or proliferative lupus nephritis. So over to you, Dr. Amrita.
Good evening to one and all. Today I'll be discussing kidney dysfunction in lupus. Is it always lupus nephritis? We'll be discussing two case scenarios. Our first patient is a 22-year-old female who's a known case of lupus. She is incidentally found to have 3+ protein on her urine routine, not much of active sediments. She is normotensive, her creatinine is normal. The 24-hour urine protein is 3.8 grams per day. In this patient, our first differentials would be class 5 nephritis or a combination of class 3, 5 or 4 and 5, or it could be none of these. We will come back to the diagnosis after the biopsy. Our second patient is a 42-year-old male, again a known case of lupus. He presents with anasarca since 1 month. This patient is hypertensive. He has AKI, creatinine is 2.6. His urine protein shows 3+ protein, but not much of active sediments. And the 24-hour urine protein is a very high 11.5 grams per day. In this patient, the differentials would be active lupus nephritis 3 or 4. It could be tubulointerstitial nephritis. It could be SLE with TMA, or it could be none of these. Coming to the biopsies of both these patients. In our first patient, we can see here, in the light microscopy, the glomerulus looks pretty much normal. And in the immunofluorescence, there are hardly any immune deposits. This is a typical finding of minimal change disease, which is a type of lupus podocytopathy. In our second patient, the light microscopy shows sclerosis of parts of the glomerular tuft, and the immunofluorescence again shows minimal immune deposits. And this is a feature characteristic of focal segmental glomerulosclerosis. So in these two, the common feature to be seen is there is absence of other features of active lupus nephritis, such as crescents, endocapillary proliferation, fibrinoid necrosis, or subendothelial or epithelial deposits. Only in the absence of these can we make a diagnosis of lupus podocytopathy. There's one more variant, the mesangial proliferation variant, where there can be a slight increase in the mesangial matrix in cellularity, and on immunofluorescence, there might be scanty mesangial immune deposits. So minimal change disease, FSGS, and mesangial proliferation are the 3 types of lupus podocytopathy. Now, lupus podocytopathy is a distinct type of lupus nephritis. It is uncommon. It accounts for less than 1% of all biopsies. Patients typically present with nephrotic range proteinuria. They may or may not have hypertension and AKI. Hypertension and AKI are more common in the FSGS variant, as seen in our second patient. The minimal change disease patients typically present with a nephrotic range proteinuria without any other accompanying symptoms. This table shows us the diagnostic criteria for podocytopathy. So the clinical criteria is a diagnosis of lupus with nephrotic range proteinuria. Light microscopy, any of these patterns can be seen. minimal change disease, mesangial proliferation, or FSGS, but without the other features suggestive of active immune complexes mediated nephritis. Immunofluorescence is typically negative. Some amount of mesangial deposition is permitted. The most characteristic morphologic feature is seen on electron microscopy, where there is a foot process effacement of more than 50%. To diagnose podocytopathy, all the flow criteria have to be met. So in this picture, we can see a normal glomerulus. This is the glomerular endothelial lining, the intact glomerular basement membrane, and the podocyte's foot processes with intact slit diaphragms between each foot process. So what happens in podocytopathy is there is an extensive effacement of the foot process and a fusion. So for diagnosis, we require a cutoff of 50%. However, in most patients, it reaches up to a 90 or 100%. Moving on to the management of podocytopathy, steroids, as in other forms of nephritis, form the cornerstone of treatment. We start with 0.5 to 1 milligram per kilogram of prednisone. The minimal change disease variant, similar to the idiopathic form in children, is highly steroid responsive. Up to 90% of patients may achieve complete remission within 4 weeks of steroid monotherapy. However, on the other hand, FSGS may be slightly steroid resistant. Only about 40 to 50% of patients achieve partial or complete remission with 8 weeks of steroid therapy. But nevertheless, in either case, steroids do work. However, the problem with steroid monotherapy is high rate of relapses, and therefore steroids have to be combined with a second-line immunosuppressive agent. Among these drugs, the best studied are the calcineurin inhibitors. Particularly, tacrolimus has been shown to have the best remission rates and long-term renal outcomes. Other drugs such as MMF, rituximab, and cyclophosphamide have been tried. They have good benefit in patients with recurrent relapses. With this, I conclude. Thank you. These are my references.
Thank you. Thanks a lot, Dr. Amrita. That was so. Accordingly, if there is lupus podocytopathy, a choice of immunosuppression changes. We would prefer a calcineurin inhibitor over others, or we treat according to the extra renal manifestation of lupus. So another tricky situation in lupus that we come across is during pregnancy. A pregnant lady who comes to us towards the end of her pregnancy with hypertension and AKI. So this is a common but tricky scenario which will be dealt with by Dr. Digvijay.
Very good evening to all. It is a curious case of lupus nephritis. I'll just go through the brief details of the case in first slide. 28-year-old female. She presented to emergency with GTCS and blood pressure of 160 by 100. On inquiring, she gave history of oral ulcers, photosensitive rash, and arthritis in past. Also, recent history 1 week back, history of PIH and intrauterine death. Also, her investigations revealed that HB of 5.1, total leukocyte count of 2500 and platelet of 45,000, and peripheral smear showed reduced platelets with 4% of schistocytes, and creatinine was 2 milligram percent. So it is quite evident that this patient may have microangiopathic hemolytic anemia with thrombocytopenia. Also, her urine routine showed albumin and active sediments. Also, her 24-hour urinary protein showed it was 5 gram per 24 hour. And ANA was 3 plus 4 speckled, and dsDNA was positive. And also on further testing, the LAC was positive and anticardiolipin IgG was positive. So my differentials at this point, MAHA plus thrombocytopenia with there are differentials. It can be SL with AKI with proteinuria, SLE with proliferative nephritis, which is having nephritic sediments, proteinuria, hypertension, and raised creatinine. Yes. Will kidney biopsy help? Yes. To classify the class or to let us know the class of the lupus nephritis, it will definitely help, and to deal with further immunosuppression. It can be SLE with TTP, yes, MAHA, TCP, and she had seizure, neurologic symptom, fever was not there, but and renal failure was is there in TTP. Yes, kidney biopsy may take may help to take us a call on plex. Again, another situation is SLE with caps. Again, pregnant arterial or venous thrombosis greater than 3 organs simultaneously in a less than 1 week, and also there will be histologic evidence of thrombotic microangiopathy will be there. Yes, and kidney biopsy will help to decide us on further anticoagulation. Again, delayed HELP syndrome. HELP syndrome occurs in mostly last trimester of pregnancy. Few cases can go up to the first 4 weeks postpartum. It presents with liver dysfunction, renal failure, neurologic complication, and bleeding. Maybe non-fatal complications like pulmonary edema and pushes like retinopathy. In this case, there was no liver dysfunction, and her PT, APTT, PTINR, APTT was normal. Kidney biopsy will not help us in any in case of delayed HELP syndrome. Another DD would be DIC, presence of MAHA, but there will be bleeding, prolonged PTINR, and raised FDP, which is quite sensitive for DIC, and kidney biopsy won't help us in that. So we did kidney biopsy in this case, and it showed presence of wire looping with activity index of 7 and chronicity index of 3. There were microthrombi, which is visible in this slide, and immunofluorescence showed full house pattern. And you can see this wire looping here, massive, which are suggestive of massive subendothelial deposits. So it is DPGN class 4 lupus nephritis with thrombotic microangiopathy in a case of SLE with secondary APS. Yes, how kidney biopsy helped us in this case is it helped us beyond the classification of lupus nephritis, so that there was presence of TMA, which classified for treatment of anticoagulation. So the diagnosis was SLE with secondary APS, CAPS. We treated her with pulse MPS, plasma exchange, and anticoagulation once the platelet count was above 50,000, and supportive treatment like antibiotics and other IV fluids, followed by prednisolone 1 mg per kg per day with taper. IV pulse cyclophosphamide, NIH protocol we routinely use because there was presence of lupus nephritis, along with HCQ, ACE inhibitors, and other supportive treatment. And anticoagulation was continued. Patient is doing well on this follow-up. Now the 4th month is there. So a brief discussion about this case. Thrombotic microangiopathy is present in 25% cases of biopsy-proven lupus nephritis. Most commonly associated with class 4 lupus nephritis. 80 to 75% or to 80% cases it is present with class 4. Lupus nephritis plus TMA, there are higher levels of proteinuria, higher serum creatinine, higher frequency of systemic hypertension, and worse renal prognosis, and increase in overt active and chronic lesions. Uh, and TMA is significantly associated with presence of FPLs, particularly lupus anticoagulant. Treatment of SLE TMA in presence of APLA is anticoagulation, first LMWH, then VAR with target INR of 2 to 3 plus HCQ plus ASARB, and plus immunosuppression like cyclophosphamide or mycophenolate mofetil as per the underlying class of lupus nephritis is considered. In refractory cases, we can use rituximab, and also the new upcoming drug because oclizumab, because there are studies which denote that there is complement mediated damage in cases of thrombotic microangiopathy. With this, I conclude my slides.
Thank you, Dr. Digvijay. Something similar to this is in a setting of primary antiphospholipid syndrome. Dr. Kunal will discuss about different presentations where in primary Sjogren's syndrome, which actually needs renal biopsy. Over to you, Dr. Kunal.
Good evening, everyone. So I'll be discussing regarding renal involvement in Sjogren's syndrome. We'll start with a small case. So we have a 38-year-old female who is a known case of primary Sjogren's syndrome and has a history of nephrolithiasis. She came to us with complaint of weakness, and wherein she was unable to get out of bed or a chair without assistance. On examination, this diffuse weakness with no other neurological abnormalities. The labs are grossly normal, except a potassium of 1.9, a bicarb of 19, and a pH of 7.21. And the urine RM shows a protein that is 2 plus and a pH that is slightly high on the higher side, that is 5.9. So what is happening to this patient and what to do now? What are the clinical clues of renal disease in Sjogren's syndrome? So a history of polyuria, polydipsia, muscle weakness, nephrolithiasis, and or nephrocalcinosis would suggest renal involvement in Sjogren's syndrome, and a lab that is suggestive of hypokalemia, elevated creatinines or altered renal functions, a non-anionic gap metabolic acidosis, an elevated urine pH, and a proteinuria would suggest renal involvement. Now, renal involvement in Sjogren's syndrome is usually asymptomatic and insidious. Can occur in up to 50% of patients having Sjogren's syndrome. And TIN is the most frequent involvement. It occurs in almost 98%, 50 to 98% of patients having renal involvement. Biopsy usually shows lymphocytic infiltrates that may progressively lead to atrophy and fibrosis of the tubulointestinal system and lead to a chronic kidney disease. The lymphocytic infiltrates also lead to an alpha intercalated cell dysfunction that leads to decreased hydrogen ion secretion and a non-anionic gap metabolic acidosis. Since there's decreased hydrogen ion secretion, there's a compensatory increase in potassium secretion in the urine that leads to hypokalemia and cramps and periodic paralysis. And also because of impaired reabsorption, there's increased calcium and phosphorus secretion. This leads to nephrolithiasis. This proteinuria, which is usually low molecular weight, so dipstick is often falsely negative. Glomerulonephritis is unusual, presents acutely, can occur in up to 2 to 23% of patients, and the most common manifestation is membranoproliferative glomerulonephritis. Yet, if you find glomerulonephritis, you need to first rule out other pathologies such as lupus or an antavasculitis. Diabetes insipidus can occur concurrently with any of the other manifestations and is rarely symptomatic. This is the biopsy of this patient, and this shows lymphocytic infiltrate in the interstitial space. Now, a renal biopsy and Sjogren's syndrome. So when is a renal biopsy indicated? So if you have altered renal function in the patient of primary Sjogren's, you need to do a renal biopsy. Persistent or significant proteinuria is another indication. A rapidly progressive renal dysfunction does alter your therapeutics, and hence an urgent renal biopsy is required. And a patient who is non-responsive, resistant to treatment would require another. What is the role of renal biopsy? So it does define the type and extent of the lesion and helps in guiding the therapy. Tubulointestinal nephritis and glomerulonephritis can commonly coexist. So a patient who has renal tubular acidosis and significant proteinuria, you need to rule out the coexistence of both because therapies differ. And it helps determine which set of patients would require aggressive therapy. This is this is a review of all the different studies that happened regarding renal biopsies. And we find that tubulointestinal nephritis has been present in almost 30 to 80% of patients, followed by membranoproliferative glomerulonephritis, which is usually secondary to type 2 cryoglobulinemia, can occur in up to 30% of patients. Membranous glomerulonephropathy, IgA nephropathy, FSGS can occur in variable percentage of patients from 2 to 15, and minimal change disease and diffuse glomerulosclerosis in around 5% of patients. Crescentic glomerulonephritis, that is a rapidly progressive serious variant, is only present in case reports. Now, what do we do with all this information? So we decide on what to treat. So the renal involvement can be in form of tubulointestinal nephritis. If there is only a distal renal tubular acidosis, only bicarb and potassium supplementation is required. and you need to monitor for nephrolithiasis. If there's diabetes insipidus that is present, no specific manifestation is usually required because of sicker symptoms. These patients do drink a lot of water. Renal dysfunction, if there's renal dysfunction present, you need to start steroids at 0.5 to 1 milligram per kilogram and then taper it over next 3 to 6 months. And mycophenolate mofetil or azathioprine can be chosen as the steroid sparing agent. And in patients who are resistant to treatment, rituximab can be tried. For glomerulonephritis, as I said, you need to rule out other pathologies first. You need to rule out lupus or ANCA. And rituximab has the maximum data regarding effectiveness in treatment. And this has to be started with tapering doses of steroids. For a patient who has a rapidly progressive disease or life-threatening disease, plasma exchange is the treatment of choice. And cyclophosphamide, azathioprine, or MMF can be tried according to patient viabilities, economic viabilities, and patient choices. Thank you. These are my references.
Thank you so much, Dr. Kunal. So basically, we have to do a biopsy to rule out if there is a coexisting glomerulonephritis. That is the most important thing for us to do a biopsy in primary Sjogren's syndrome. Another untouched topic is vasculitis, especially something like IgA vasculitis or henoch-Schönlein purpura, where we are not very sure where the scenarios wherein immunosuppression works for these patients. And one such scenario is renal involvement. Dr. Rudrarpan will tell us more about one such case.
Good evening, everyone. I'm Dr. Rudrarpan from SGPGI, and I'll be taking up 5 more minutes of your weekend. So this is a 16-year-old boy who had a history 6 years back of classic HSP with pain, abdomen, arthritis, and purpura. And at present, he came to us with a history of macroscopic hematuria. He was hypertensive, and his urine routine was full of RBCs, and his 24-hour urine protein was around 3.15 grams. So this is the histopathology. You can see there were crescents in 7 out of 15 glomeruli visualized, some amount of mild interstitial infiltrates, inflammation, and IgA, granular IgA positivity on the immunofluorescence. And this was reported as HSP nephritis, ISKDC class 3. So this ISKDC classification is actually a qualitative classification. It looks at class 1 as a minimal histologic lesion where glomeruli are normocellular. Class 2 is a focal segmental glomerular sclerosis type of presentation. Class 3 and class 4 are dependent on the cellularity and the crescents. So less than 50% cellularity or less than 50% crescents is class 3. And class 4 is more than 50% cellularity or more than 50% crescents. Whereas class 5 is advanced chronic glomerulonephritis, or 40% are glomerulally sclerotic, or 40% estimated tubular loss. So in 2019, a group of pediatric nephrologists and rheumatologists came up with this SHARE initiative, and they published a set of recommendations for management of such patients. And the tone of the recommendations actually recommend further research. So as you can see, the level of evidence is quite poor. Level of evidence 4 and strength of recommendation D for all of these recommendations. And they first classified the proteinuria into mild, moderate, and severe proteinuria. So mild proteinuria of less than 1 gram, moderate is 1 gram to 2.5 grams, and severe is more than 2.5 grams for 24 hours, all persistent for more than 4 weeks. And based on this persistent proteinuria was defined. So that is a UP-UC ratio of more than 250 milligram per millimoles for 4 weeks. A UP-UC ratio of more than 100 milligram per millimole for 3 months, or a UP-UC ratio of more than 50 milligram per millimole for 6 months. So these are the definitions of persistent proteinuria. 250, 150 here correspond to 2.51 and 0.5 in what we deal with. And based on this, they divided into mild, moderate, and severe nephritis. So mild nephritis would be a normal GFR and mild or moderate proteinuria. Moderate nephritis would be less than 50% crescents on the biopsy and impaired GFR or severe persistent proteinuria. So this is the class that our patient falls in, moderate nephritis. And severe nephritis is more than 50% crescents on the renal biopsy and impaired GFR or severe persistent proteinuria. So based on these classification of mild, moderate, and severe nephritis, you can have management strategies. So a patient who has microscopic hematuria without renal dysfunction and proteinuria, or if the patient has non-persistent mild or moderate proteinuria alone, can be followed up without any treatment. If the patient has severe proteinuria or impaired GFR, or if the patient has persistent proteinuria as per this definition, then we need to consult a pediatric nephrologist and perform a renal biopsy. So based on this biopsy, if we have mild nephritis, the first line therapy is just oral prednisolone. And the second line could be azathioprine, MMF, or pulse methylprednisolone, depending on the response. For patients with moderate nephritis, you go for a first line of oral prednisolone with or without pulsed methylprednisolone. And first or second line, you can have azathioprine, MMF, or IV cyclophosphamide. We went with MMF for this patient. And severe nephritis, the first line would be IV cyclophosphamide with pulsed methylprednisolone and oral prednisolone maintenance. And second line would be azathioprine, MMF with steroid therapy. Further, we should consider anti-proteinuric measures, so ACE inhibitors in all patients. And right now, oral cyclophosphamide and cyclosporin A are not routinely recommended. So what are the factors that predict poor outcomes in these patients? This was a systematic review and meta-analysis of 9 studies, including 969 patients, and they looked at unfavorable outcomes in terms of Meadows grade C disease, that is active renal disease, with hypertension, proteinuria of more than 40 milligram per meter square per hour, and increased serum creatinine, or Meadows grade D, that is uremia or ESRD, dialysis dependence, or renal transplantation requirement. And for these unfavorable outcomes, age at presentation, so increased age, EGFR at baseline, so decreased EGFR at baseline, presence of nephrotic syndrome, presence of nephrotic syndrome alone, or crescentric glomerulonephritis on the biopsy, all are significantly associated with poor renal outcomes. So if the patient is having any of these at baseline and meets the criteria for persistent proteinuria, we need to biopsy this patient because that will affect the management of our IgA nephritis. Thank you.
Thank you so much, Dr. Rudratman. So basically, the management of IgA vasculitis or IgA nephropathy depends on histopathology, and the histopathology of kidney is required for planning management. So to summarize, what we found was we have an opportunity in the form of lupus podocytopathy if we do a biopsy in a nephrotic syndrome in lupus. And if we find a TMA on biopsy, it will help us to prognosticate as well as plan treatment, especially in the case we saw, which was a CAPS case with SLE, where she needed immunosuppression for lifelong probably. And in case of APS nephropathy, which we could not discuss due to some connectivity issues, even here biopsy will help in deciding need for immunosuppression, if there is a need for immunosuppression at all, especially if there is a concomitant membranous glomerulonephropathy in case of APS. And in primary Sjogren's syndrome, biopsy is needed if only potassium citrate. Biopsy is needed in cases of coexisting glomerulonephritis, and if only potassium citrate is insufficient to control the renal disease. In IgA vasculitis, the indication and magnitude of immunosuppression will be based on both clinical parameters as well as histopathological findings. So biopsy can change our management for these patients. So let us all start doing biopsy, but judiciously. Thank you.
Okay. So there is one question for your session from Suparna Guha. Class 3 lupus nephritis, treatment endoxan 6 monthly followed by MMF 2.5 gram per day, still high activity, urea creatinine normal, 24-hour urine protein 450 milligram. Do you advocate repeat biopsy or just hike up immunosuppression in the form of rituximab?
So first of all, we don't know the baseline proteinuria.
Yeah.
24-hour urine protein of 450 milligram actually shows some amount of response in this patient.
Correct.
So we are not sure of her disease activity. Extra renal, we are not sure.
Yeah.
So for renal activity, at least I would not do a biopsy in this case. We would continue the immunosuppression and wait. It usually takes about a year to get complete response in cases of lupus nephritis, and it is worthwhile waiting up to 2 years if there is no progress.
Yeah. Thank you. It was so wonderful, as young people always want to teach more, want to impress more, and they all had done in a very brief presentation. They have highlighted uh, practical problems. So Chengappa is a very able organizer now after IDACON. He is a very capable and bright associate professor in clinical immunology and rheumatology at JIPMER Pondicherry. So um, I thank Chengappa for conducting this session with young people brightly. I would now go back to the last part of the session, which is again coming back to Professor Ritamra Nada. She is going to conduct this session on interpretation of nerve muscle, skin, and minosalivary gland histopathology. Dr. Ritamra Nada, please welcome and over to you.
So I'm back again. So now I shall continue to talk about histopathologist's role. So I'll talk about histopathology of nerve, muscle, skin, and minor salivary glands. So first of all, I'll start with the skin. As you see, skin biopsy, as we receive the kidney biopsy, similarly, skin biopsies are also received in Michel's media and one core in neutral buffered saline. And they are again treated the same way, like frozen section are cut from biopsy center Michel's media. And generally in this the whole panel is not done. Generally IgG, C3 and C1, IgG, AM and C3, C1q are done. Kappa lambda are not done. Fibrinogen is done according to the requirement. So as you see, this is a normal biopsy. I've just put it for the sake of comparison. So look at the point to be noted is the thickness of the epidermis. This part is dermis, and what we have to note the thickness of this and the texture of this. So this biopsy is from a patient of lupus nephritis. So we can see marked difference. So what are the difference we are seeing here? First thing that this is a epidermis and this is a keratin layer. So we are seeing hyperkeratosis. We see this kind of blue nuclei in the superficial layer, which is called hypergranulosis. So you see there's marked blue color here, which indicates hypergranulosis. The thickness of the whole is also increased as compared to these areas. So hyper there's hyperkeratosis, hypergranulosis, and acanthosis. These are the terminologies used. And another thing which is very evident here is that there is lots of blue color here in the upper dermis. Lower dermis is relatively fine. And another point, if you see here, the hair follicle is dilated. So this is what we call hair follicular plugging. This is just a high part of the same. You see that there is at dermoepidermal junction, you see lots of inflammation, which is mainly lymphoplasmacytic. This inflammation is extending into the epidermis. You see these cells which have gone in. Because of this, there is separation, which we call spongiosis. And these kind of pink cells, which are devoid of nuclei, are called apoptosis. So this is a dermoepidermal reaction, which is seen in lupus cases of lupus in biopsy taken from patients of lupus, discoid lupus erythematosus. And as you see here, the nature of cells are lymphoplasmacytic. And this paleness which you are seeing here is mainly because of mucinous material, and this turns out to be algin blue positive. Inflammation is seen around the blood vessel, not within the blood vessel. So this is perivascular lymphomononuclear infiltrate. In all cases of in cases where we are expecting lupus biopsy from the lupus patients, we do an immunofluorescence. As you see, at the junction of dermis and epidermis, we are seeing a band with IgG and C3. This was IgG, which is a linear band seen here, and it goes around the hair follicle as well. And in some cases, you may even find presence of this immunoglobulins within the capillaries. So these are the capillaries which are showing you band and a lupus band, which what we call. So when we have to differentiate between lupus and discoid lupus, what we have to do is the biopsy is taken from unexposed areas and exposed areas. Both are given, and if the band is seen in both the sites, then it is lupus erythematosus, and if it is seen only in the exposed area, then it is discoid lupus erythematosus. Another indication of biopsy in rheumatological diseases is this. This I shall show you. So here you see the skin epidermis is normal, mid dermis and lower dermis are showing us changes. And if you see, this pattern of inflammation is extending along a preformed structure. So we tend to look for this kind of inflammation, and this is looking very pink. Normally, we don't have this kind of a pink material in the dermis. It is supposed to be something like this, but here we are seeing a very deeply pink material accompanied with this inflammation. So this pink material, as you see, is not very haline looking. It is a fibrinoid necrosis. So fibrinoid necrosis, which is present along these channels, is fibrinoid necrosis of a arteriolar wall. So what we are seeing is basically a fibrinoid necrosis. At a higher power, you can appreciate this is the endothelial lining. Then we are seeing this amorphous pinkish fibrillar material and inflammation, which is comprising of lymphomononuclear cells and some eosinophils. Here again, this kind of material, which is very deep pink in color and is structureless, is called fibrinoid necrosis, and this is perivascular lymphoplasmacytic inflammation. So this comprises vasculitis. Uh, we have to make a note that there is no granuloma formation, there are no giant cells here. And in addition, in cases, so this was vasculitis. So another picture, just to highlight one point, that in presence of vasculitis, one should always also try to look at subcutaneous tissue if available. Generally, biopsies would have some amount of deeper tissue. So this deeper tissue is showing us again vasculitis and inflammation, which we call paniculitis. And how you identify vasculitis is because you can see a structure, a longitudinal structure like this, where this is the wall of an artery. There is fibrinoid necrosis of the wall, which is extending outside. And whenever there is endothelial injury, there tends to be a thrombus formation within the lumen. So we are seeing a superimposed thrombus. No granuloma is seen, and if you see, the nature of inflammatory cell in this area are largely eosinophils. So a presence of vasculitis with superimposed thrombus, absence of granuloma, and rich in eosinophils, this would be my diagnosis for this particular case. I cannot say whether this is PAN. I cannot say whether this is a small vessel vasculitis or it is any other type of vasculitis, because as a morphologist, we can restrict only to the presence of vasculitis, but we may give indicators enough which may, in a clinical scenario, would be consistent with one particular kind of vasculitis. For example, this vasculitis, if this patient was C ANCA positive, could be a uh, ANCA associated vasculitis, which is C ANCA positive, so it will be consistent with GPA. But uh, if suppose I had seen some granulomatous inflammation, again it would have given this support for being a GP associated vasculitis. But in absence of that, I would leave it at vasculitis. Presence of eosinophils in this inflammation might indicate that this patient may be having an EGPA or EGPA. So, but other vasculitis can also have eosinophils. So, as a morphologist, we just leave in the diagnostic line the presence of eosinophils and presence of paniculitis, because it will explain the clinical picture of the patient having tender nodules. And this fibrinoid necrosis is a marker of acute inflammation. If this biopsy was done little later, what we would have seen is absence of any fibrin, presence of only ruptured uh, elastica and some lymphomononuclear infiltrate. Now, coming to nerve biopsy. Nerve biopsy is sent to us in cases where generally PAN is suspected or vasculitis is suspected, because mononeuritis multiplex is an important manifestation of polyarteritis nodosa. So this is how we recognize a nerve. These are the nerve bundles, and this is the perineurium, and this is the in, this is the connective tissue in between. Normally, you would find these kind of small blood vessels here, but what we are seeing in this particular case is one artery having again same kind of fibrinous material and inflammation. Same artery, if traced at different level, again shows you extensive presence of fibrinoid necrosis, presence of inflammation both in the wall and in the adventitia. Because of these changes, we are seeing increased amount of fibrosis in between these nerve bundles, and this part of the nerve is normal. Here again, just to this is again the same picture, and just to show you the segmental nature of this process. Here we see these two arteries are involved, whereas intervening these smaller branches are free of it. This is to show you that there is fibrinoid necrosis and luminal damage resulting in occlusion, which would have contributed to the perineural fibrosis. Then in this picture, what I want to show is that this inflammation extends beyond this also, so beyond the artery. So this kind of adventitial inflammation can also be seen, but it does not help us distinguish between different kind of vasculitis. The effect of this vasculitis on nerve bundle, it being of some duration, would be highlighted in terms of loss of this myelin. The myelin appears, this is a special stain for myelin, which we call LFBPAs, where this myelin normally would be this blue in color, but here we see some fibers are not that deep blue. In this area, as you see in a cross section, we always cut the nerve into transverse section and longitudinal section, because transverse sections are better for interpretation of demyelination. So as you see here, this part is quite blue in color, but here we see loss of blue color. So these areas are representing demyelination, better brought out at this high magnification. Normally we should see this blue color in each of it, but they are missing. That means the impact of it was there in the form of demyelination. So this case represents a vasculitis with evidence of demyelination. In some cases, if the biopsy has been done little later, instead of getting acute vasculitic process, you may have an artery showing you recanalized thrombi, which, because thrombosis is a process which can happen in any kind of vasculitis. So here you see an artery which is showing you three channels instead of single channel. So that means there was a thrombus here following vasculitis which has got recanalized. So this indicates a chronic process, and because of that we are seeing so much of fibrosis in between the nerve bundles. The same biopsy, as you see here, inflammation is here, and one small branch of artery shows us loss of elastic tissue. This is a normal elastic tissue in elastic von Gizon stain, whereas here we see this black tissue has been lost, which indicates that there was vasculitis here, but it has healed, and because of this the chronic fibrosis is seen in between the nerve fibers, and we saw the presence of demyelination. Now coming to muscle. Muscle again, as kidney biopsy and skin biopsy, we these sections are snap frozen, and they are cut. The frozen sections are cut and stained with these hematoxylin and panel of IHC stain depending upon the indication. However, in cases of rheumatological diseases, we do not need any special IHC, because what we are looking for is only the inflammation, which is required to label it as inflammatory myopathy. So what we are seeing here is these are the normal muscle bundles, these are the endomysium, and these are the blood vessels. So what we need to report is any evidence of vasculitis if it is present, and presence of inflammation with destruction of myocytes. So as you see, there is here intramyocytal inflammation, as well as there is destruction of myocytes because of these lymphomononuclear cells. The nature of cells, as you see, is plasma cells and lymphocytes here. So there is intramyocytal inflammation resulting in damage to the myocytes. Normally, it should be uniform in color like this and a peripheral nucleus, but here you see some of them have atrophied, they have become small, and you can see some of them are having central nuclei and evidence of some degeneration in the form of this kind of different color within the muscle fibers. So this is a case of polymyositis or inflammatory myopathy. Impact of these the vascular changes may are sometimes also identified in resected specimens from a sent in emergency, like we receive gangrenous bowel, and in that case it's very important for us to look at the cause of gangrene. Most often you would find some cause, you have to have some cause of this infarction. As you see in this case, we are having presence of this chronic vasculitis here, acute active vasculitis, and some subacute vasculitis in submucosal arteries of one gut, which was removed for gangrene. So, as a histopathologist, we should always keep an eye on vessels whenever gangrenous segments are sent to us. Now coming to lip biopsy. So minor salivary glands are important parts of investigations in cases of Sjogren's syndrome, or when you have to do the scoring of these salivary glands. So and there are four scores which are identified. The score 0 would be when there is no to minimal inflammation with preservation of acinar cell. So this is the normal salivary gland. These are the ducts, and these are the main areas where we have to look for inflammation. So as you see here, these ducts are looking very normal. There's no inflammation, and these are the glandular component where again there is absence of any inflammation or destruction. In score 1, we will have occasional lymphomononuclear collection with no SNR destruction. So site of inflammation again would be here. So this is one of the simplest ways of assessing, though there are many ways of doing it more objectively, but in practical use, this is the scoring which we is used. So you are having some perivascular inflammation, but no destruction of SNR tissue. Score 2 is when you have two or more lymphomononuclear aggregates in the interstitium without SNR destruction. So once again, there you see this inflammation here, SNR tissues seen, but no destruction. So there were more than two aggregates. So this becomes score 2. Score 3 is when there is diffuse interstitial lymphomononuclear infiltrate and partial SNR destruction. So here you see that there is lots of inflammation in this area, and you see that there is these the paler areas which were glands are now being replaced by this inflammatory infiltrate. You can see the destruction of these SNR cells. Since we know that IgG4 related disease is also and also involves the salivary glands. So nowadays we always do IgG4 staining to rule out any IgG4 mediated disease, and in these cases it would be negative. So this is again to show you that dense perivascular periductal inflammation with destruction of SNR tissue would be score 3. Score 4 would be when there is diffuse interstitial infiltrate with near total destruction of SNR tissue and fat infiltration in the parenchyma, fat infiltration always indicates that this is a chronic process. So as you see here, we are seeing that there's extensive loss of this kind of normal SNR tissue. They are dilated. That means the ducts are being obstructed because of this inflammatory process. And in some areas, you see that there are collections of lymphoplasmacytic cells, and SNR dilatation indicates that there is ductal obstruction, and presence of fat also indicates a chronic extensive damage. That means all these areas were occupied by SNR tissue which was fibrosed, and later on lipid metaplasia occurs. So this is all I have to talk about other connective tissue conditions where we do this histopathological assessment. Thank you.
Thank you, Professor Ritamra, for such a beautiful elucidation of histopathology and the relevant other stainings in uh, skin and muscle and nerve and salivary gland biopsy. Uh, Before I go to the uh, anything else, there is a couple of question, and also on small announcement from Dr. Chengappa that one of the speakers among the panelists who could not present because of technical issues is ready now. So I'll just complete with the questions first and then go to the last part. So this here is a question from uh, Dr. Rudrapan. Some of the dystrophies like LGMD can also have inflammation. Can they be differentiated from idiopathic inflammatory myositis on histopathology alone, or immunohistochemistry is a must?
I think histopathology alone will never be sufficient. In fact, muscle biopsy interpretation is done always with the whole panel of immunohistochemistry. In the sense, there is NADPH, and there are many other. Almost, we have a panel of 25 antibodies which are done routinely for muscle biopsy interpretation. But as far as rheumatological conditions are concerned, we are mainly concerned with polymyositis. So for that, we don't really need any special one of these enzyme immunohistochemistries, because presence of inflammatory infiltrate, at the best people do MAC staining, that is C5 to 9 MAC staining, which stains these vasculature. And HLA-DR is the one which is used, which is upregulated in cases, upregulated in cases of this polymyositis. So these are the only two stains which are done in these kind of settings. Otherwise, those all are done for kind of a dystrophic myopathies, for which the clinical scenarios are always different. So that is why I did, because that's a huge lecture by itself, and it's not within the purview of rheumatological diseases. So if you are suspecting those kind of situations, then you may need whole spectrum of immunohistochemical panel needs to be done. So it's your clinical
Uh,
scenario which will direct you like how much workup needs to be done.
Oh, thank you. I have just one curiosity out of my own curiosity. Madam, do you not consider Daniel scoring these days anymore? And because actually absolute focus score is something when it comes to research is recommended. And Daniel scoring is something which you used to follow for salivary gland histopathology, where we have grade 1 to 4, and if you go to grade 3 it becomes focus score of 1. And actually you can objectivize the score by taking ratios. It can become 1.5 or 1.8 or 1.7. So can you highlight 2 minutes on Daniel scoring if you are in the
Like for now,
practice
it's
of
been a
doing it?
practice to do focal scoring only, because it's quite objective, and like for comparison sake, our
Yes,
clinicians
yes,
prefer that. So now it's become a kind of habit to
right.
score them and do it this
Absolutely,
way. Otherwise, earlier we
absolutely.
used to do it, but now almost everybody's
Yeah.
kind of getting to
Absolutely.
it.
Correct. Thank you. I have two other questions, but I'll go into it later. I think Dr. Abhita is waiting. She had to present on APS nephropathy uh, in the panel discussion. So please finish in 5 minutes, Dr. Abhita.
Good evening, one and all. Myself, Dr. Abida Aliar, KIMS DNB resident at KIMS Secunderabad. So let's move on to the case. So here we have a 42-year-old lady. She is a non-case of primary APS with past history of ischemic CVA. Was on treatment but discontinued 3 years back. Since then, she was asymptomatic. But for past 6 months, she presented with new onset hypertension, increasing proteinuria of 1.2 gram per day with active sediments and worsening creatinine to 2.6. She didn't have any evidence of other CTD or comorbidities. So in this setting, when a patient of primary or secondary APS presents with this scenario, what all differences should be considered? The first one should be APS nephropathy, which is a non-criteria manifestation of APS. Here it is a intrarenal small vessel vasculopathy, and which may present acutely or chronically. So in primary APS, variable prevalence of around 2.7 to 9%. but more prevalence is seen in SLE, APS, and CAPS, around more than 50%. Patient may present chronically with hypertension, proteinuria, generally subnephrotic, and with active sediments and AKI. In the case of acute setting, and renal biopsy would help us in identifying this condition. And the next DD would be glomerular disease, but which is more rarer. And in that, membranous glomerulonephritis is the common presentation. Others are MCD and FSGS. Here again, renal biopsy will tell us. Other less common DDs would be renal artery disease, either stenosis, thrombosis, or infarction, or renal vein thrombosis. And renal vessel imaging would help us in differentiating this. And in this lady, the renal vessel imaging was normal, and we proceeded with the renal biopsy. So, when an APS nephropathy presents acutely, it presents as a TMA. As we had a previous case where an SLE APS patient presented with TMA, which will show fibrinoid necrosis and fragmented erythrocyte misangiolysis, and which may involve glomerulus, preglomerular arterioles, and interlobular arteries. And in later stages, you can see a reduplication of the basement membrane. Chronic lesions are typically arterial or arteriolosclerosis with fibrous intimal hyperplasia, occluding the vascular lumen, and there may be organizing thrombi and focal cortical atrophy, mainly involving the subcapsular cortex, which shows sclerotic or pseudocystic glomeruli with the dense interstitial fibrosis in tubular atrophy with thyroidization, where there is colloidal cast within the lumen of the tubules resembling the thyroid tissue. So coming to the management here, as we all know that it's complement dependent in acute TMA. So APS secondary to SLE and lupus nephritis, along with anticoagulation, we have to intensely immunosuppress the patient. And here the renal biopsy will be mandatory to differentiate the immune complex nephritis from the APSN, which is a non-inflammatory vasculopathy with no immune deposits. And in refractory cases, we can use rituximab. In acute APS nephropathy presenting as TMA, it's anticoagulation, plasmapheresis, and eculizumab as a rescue therapy, as they have tried in graft recipients with APS, where eculizumab worked well. And in nephropathy in catastrophic APS, again, AC inhibitors, antihypertensives, anticoagulation with pulse steroid, IVIG, and the rituximab. And coming to APS nephropathy in renal graft recipients, along with anticoagulation, they have found sirolimus, which is an mTOR pathway inhibitor, as mTOR pathway was involved in the chronic vascular changes in the APS nephropathy. And in APS nephropathy during pregnancy, again anticoagulation. With this, I conclude my talk. Thank you.
Thank you so much, Dr. Abhita. So we need a biopsy to distinguish between SLE in a case of SLE with APS, or in APS to differentiate if there is a glomerulonephritis. So that's how biopsy is going to help us. And CAPS, of course, the prognosis has improved with the starting of the triple therapy, which comprises of immunosuppressants, anticoagulation, and plasma exchange. So thank you so much. Over to you, sir.
Thank you, Chengappa, and thank you. So I will just take 1 minute each with maybe a concluding remark from Professor Ritamra after delivering such an exhaustive session as so detailed and very useful and very relevant to all of us. So I would like you to give a take-home message to everybody, all the trainees.
Okay. So I think the most important message, according to a histopathologist, is the right kind of tissue to be given to the pathologist, because the fixation and the way it is transported really on that depends the final outcome. No immunohistochemistry, no immunofluorescence would be possible if our tissue is not good. So that is one. And once again, if you by chance are not able to take two cores, please put that core for immunofluorescence, because I can do everything out of immunofluorescence core. But if it goes into and immunofluorescence is very sensitive, like I can't differentiate, I can't diagnose class 1 or 2 in absence of a fresh immunofluorescence. Paraffin IF never gives us that good results on that. Class 3 and 4 and maybe 5 I'll be okay, but class 1 and 2 would be very difficult to dig out of that. So that is the one major message I would like to convey, that please take care of the tissue. Don't ever freeze it. Keeping at room temperature is good enough in a formalin. Never try to keep it in refrigerator, because that gives freezing artifacts or cold ischemic artifacts, which are not good for interpretation. And otherwise I think most of the diagnostics depends upon morphology, which is I've shown you most of it. But always talk to your pathologist in case your clinical scenario is not fitting in, because sometimes I may come up with a second diagnosis if we talk to each other. Like I had a case of post-immune ANCA disease, but it was progressing very fast. So when my clinician told me about that, I looked back at the slide. I did IgG4 levels, IgG4 staining, and it was markedly increased, more than 30, which would happen only in case of IgG4 related disease. Then we did serum levels, it was sky high. So there was a secondary pathology in presence of post-immune GN, but that I could pick up only because my clinician told me an atypical course. Otherwise, we assume that increased number of plasma cells are supposed to be in post-immune genes, so I would have just let it go. So the dialogue between clinicians and pathologists is kind of must in, especially in cases where you are not kind of your clinical scenario is not fitting with what we offer, and we should try to understand each other's language. There are now well defined reporting formats which we should follow, which are available now in most of the journals, and it easily accessible open access journals are there. So we let's try to do that way, so that uniformity across all reporting histopathologists and clinicians who are dealing with them should be there, because what I speak you should be able to understand, and what you are sending to me I should be able to understand. So that's very important, according to me.
Thank you
Thank
very
you.
much. And if I can add to that, as when I was a trainee, one of the things while doing salivary gland biopsies, when we used to do, I remember the pathologist used to always insist on at least there should be 4 evaluable glands. And when you take the salivary gland, they just pop out. And when you put them in the solution, either formalin or whatever solution you take it, it should not float. If it floats, it's probably fat tissue. It should sink. So,
Yeah.
and also not to forget to uh, tighten the seal. Otherwise, small glands, if it is fallen somewhere, you can never find it.
Yeah.
So,
Yeah.
with all this, I would like to say that the idea of this histopathology exposure in rheumatology training is not to make you a pathologist. That is a big thing. Pathologist is a much tougher job than ours. Our job is to be familiar with as Madam has highlighted, the common histopathological and the immunohistochemistry picture of very important and relevant rheumatological conditions. I think we should be happy with that. It's good to know more about it, but unless you have decided to sit with a microscope for rest of your life, maybe you should you become a basic scientist afterwards. I think most of you are being clinicians. You should probably have an overview, and during your training, all of you have your postings in pathology, I'm sure, histopathology, to have an exposure to that. So I think that way people get a better idea, or you have a weekly or fortnightly or monthly pathology meetings that as we used to have it here. So that is the way to keep on repeatedly seeing the same thing. Lupus, you have maybe 2 sessions, 3 sessions on lupus nephritis, 3 sessions, 4 sessions on vasculitis, and so on. So if keep repeating, I think that's the way to master this for exam purpose. You cannot become an expert in that. That you leave it to the pathologist. But I think for our exam purpose, so I think this fellows retreat over the last few years have become a grand success. And in this new norm, in a virtual form, we find that it's no less effectively communicated, rather much more efficiently, people very comfortably sitting at home and attending this. So I must thank Professor Alakindu Ghosh for arranging this, and I think his deputy, Dr. Arga, he has done the management of this,
Yeah.
and Madam has done such a beautiful job, and Chengappa and his younger team have blasted us with so much of information. And thank you, everyone. I have nothing more to add. Over to Alakendu and
Yeah.
Arghya. Yeah.
Thank you. Thank you, Devashish, for conducting this wonderful session. And thanks, Ritambara, for providing us the input to stimulate us to explain what's happening inside the patient. So that's what's required, the reasoning, and which from input from the pathologist, we could plan how to go ahead. And I think the fellows' contribution and fellows to stimulate the mind of the fellows is the main objective of this fellows retreat, because it's not for adding information or expanding knowledge. It's just to stimulate how to explain the clinical process. Thanks to Orgo for conducting and organizing and arranging everything, the background story. And we would be having our next monthly session next month. That will be on a review of literature from the teachers, along with one session again with the junior faculties and fellows on Sjogren syndrome. So, and don't forget to attend this month's IRA program and lupus as well. So that will be another exciting program, 31st October and 1st November, Saturday and Sunday, for 8 sessions. So simultaneously, these are going on. All the best and stay safe and healthy. So we'll meet in the last weekend again for our IRA meet. Thanks, Ritambar, again for helping us to go ahead with the pathologic input in clinical rheumatology. And thanks, Chengappa, for conducting with your junior fellows. Thank you. Thank you very much.